Hi everyone, welcome and thank you for joining us for today's ASA web seminar, Sustaining Programs for People Living with Dementia and Their Caregivers, Billing for Dementia Services, which is part of the National Alzheimer's and Dementia Resource Center web seminar series sponsored by the Administration for Community Living. We'll be getting started shortly. The slides for today's presentation are available under the tab on your screen marked Resources. And under the tab marked CE Application here, you'll find information on how to obtain CE credit for today's web seminar. You'll have 60 days to complete a continuing education application for today's event, and it may take up to 30 days from the date of your application in order for us to process and issue your CE credit. If you are not logged in directly to this web seminar, that is if you're watching as part of a group and didn't use an individual confirmation URL, you will not be eligible for continuing education credit because we have no way to track your online attendance. If you'd like to receive CE credit, please be sure you log in using the confirmation URL you received after individually registering. If you have questions during the presentation, you can send those at any time using the questions box, and we'll save those for the last 10 to 15 minutes of today's program. And now I'd like to welcome Sari Schumann of the National Alzheimer's and Dementia Resource Center. Welcome, Sari.
Thank you so much, Betsy, and thank you everyone for joining us today for the webinar, Sustaining Programs for People Living with Dementia and Their Caregivers, Billing for Dementia Services. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Everyone, thank you so much for taking the time out of your busy days to join us to learn more about billing for dementia care services. We want to thank Donna Wahlberg and Jill Cigliana for all of their work on this project and for the time they spent putting together presentations to teach you about what we have learned as we've been trying to traverse this rough area. So with that, thank you, and back to you, Sarah.
Thanks, Erin. Today's presenters, as you heard, are Donna Wahlberg and Jill Siguiana. Donna Wahlberg has worked in the field of aging for over 40 years. Currently, Donna works with the National Alzheimer's and Dementia Resource Center, providing technical assistance to the Administration for Community Living grantees, drawing on her years of experience working with ACL's dementia grant programs. Prior to her work with the National Alzheimer's and Dementia Resource Center, Donna spent 18 years in the field of dementia working with families, providers, physicians, researchers, educators, and policymakers. We also have with us today Jill Cigliana, who is Program Director at Memory Care Home Solutions, a nonprofit organization in St. Louis, Missouri, where she implements and evaluates evidence-based programs to improve the health and well-being of people living with dementia and their family care partners. Jill supervises an interdisciplinary team of clinicians who work to extend and improve quality time at home for clients and families through the delivery of non-pharmacological dementia interventions. She has 20 years of experience serving this population in acute, home health, and community-based settings. Jill is a licensed occupational therapist and a member of the American Occupational Therapy Association. At this time, I will turn the presentation over to Donna and Jill to get us started. Thank you so much.
Hi, this is Donna. Good afternoon. We're delighted to present this guide to billing codes for dementia services. This guide has been a long time in coming, and we're really excited that it's finally done. On this particular page, you'll see the link to the guide. I hope you've all downloaded it or will download it. And the link below that is to the NADRC website, our website, where you'll find a treasure trove of resources to support successful development and implementation of dementia services. If you've never been to our website, I would recommend that you explore it. There's an amazing amount of well-tested and fabulous information on it. The purpose of the guide is to enhance the sustainability of dementia programs and services. I've been in this business a long time, and it's something that's very dear to my heart. Is we can create services, but we have to have ways to sustain them. And while this isn't 100% cure, it is one one gap-filling possible resource. The guide features dementia services that can be reimbursed, and these are services that have been reimbursed by current or past ACL grantees, dementia grantees. The guide also includes the billing codes used and provides guidance on the basics of how to set up a medical billing code system. How the guide was developed. You'll see here a list of 6 ACL grantees who volunteered their time quite generously to be subject matter experts on the development of the guide. And the experiences and examples that are presented in the guide are from these agencies. And just by accident, they happen to equally represent the 2 target audiences of the guide. The first is those grantees that have an existing medical billing system and want to figure out how to bill for dementia services. And the other one is agencies that don't have a billing system but want to set up a billing system to bill for dementia services or other services. The billing codes that used in this guide can apply to services obviously beyond the dementia field. The information in the guide was intentionally gathered from resources that you would be using to actually develop a billing code system, and links are provided throughout the guide to those sources. One of the key issues in billing for services is that you're billing in a different culture. It's a medical billing system. So we wanted to provide some definition of key terminology to kind of help bridge that connection to the medical side and introduce you to some of their terminology and what it means. CPT and HCPCS, HCPCS is pronounced usually HCPCS, are billing codes. CPT is owned by the American Medical Association and is our medical billing codes. HCPCS is HCPCS is same exact codes, just used to bill Medicare for the same services. MACs are multi-state organizations, entities that have been given a contract to process, manage medical claims, and they're a resource to you, to billers, to figure out how to maneuver the system of billing. Local coverage determinations. I'm going to provide an example on the next slide of a local coverage determination, but I wanted to throw that in there because a local coverage determination determines how a particular billing code can be used in your state or in your MAC region. And it's actually a fairly easy thing to find out. In the guide, we include a link that allows you to put in your state, the billing code number, and it pulls up any local coverage determinations for that code. But it's an important thing to know for some services, not all of them. Jill, for instance, doesn't have that issue, but other services have to be more careful of that. Going on to the next slide. Billable dementia services. I want to give you just a few examples of the types of dementia services that have been reimbursed and perhaps you can have reimbursed. The first one, of course, is cognitive assessment. The evidence-based intervention care ecosystem uses this code set to bill physicians' time for the many components of conducting a cognitive assessment. And they also use it to bill for care planning that the physician does. And if advanced care planning is in a separate session just for the purposes of doing advanced care planning, there's a billing code for that can be reimbursed. Jill is going to explain counseling and occupational therapy billing codes. Those are the ones that she uses in her services, so I'm not going to touch on those here. The individual and group interventions, it's a new billing code set. It's possibly or is going to be, there's projects that are going to try billing reach and possibly savvy caregiver to that billing code set. Oh, and the local coverage determination I was going to talk about. In this particular individual and group intervention, you need to visit your state, find out if your state has a local determination code for this, because it's a brand new billing code set. And that will lay out the guidelines of how it might be applied to services such as Feature Savvy Caregiver. You might discover that your state doesn't have one, in which case an insurance company may or may not be willing to accept bills for that service area, and you'd have to have that discussion with them. Going on to the next slide, I just wanted to give you an example of what one of the tables in the guide looks like and the kind of information that it includes. Each table identifies the billing code, of course, and defines the procedure that you use for that billing code and the amount of time or complexity requirements for that billing code. Some billing codes are timed and some are untimed. It also includes notes, important things to know about using this billing code. And those notes come from the projects, and they're practical guidance on what they've learned and think it's important for you to know. The final column is clinicians who can bill this billing code. And it's another thing you need to check with your state and payer, because they can, the approved billers can, the approved clinicians can change from state to state and from insurance company to insurance company. So there's possible opportunity there. Elements of the billing code infrastructure. I'm not going to talk about this a great deal because Jill's going to talk about it. She's going to cover the various elements, the process to set up a billing code structure, and provide some information or guidance on the things that they've been able to do that's enhanced their success, and some of the things that you kind of want to avoid. The last slide. If you'd like more information about the guide and how the guide was developed, or some of the links, or have any questions at all, you can contact myself or Stephanie Hughes, my partner in developing the guide. We've also once again included the link to the NADRC website. With that, I'd like to pass it over to Jill, who's really the expert, and who's going to share her experience, her vast experience, in setting up a system for billing services to Medicare and third-party insurers. Jill.
Thank you, Donna and Sari and Erin. I have no financial disclosures related to this presentation, and the work I will describe is funded in part by 2 grants from the Administration for Community Living. And I appreciate the introduction as an expert, but I will preface the presentation by saying that our story certainly isn't the only way to bill for dementia services. It is just that, one organization's story, but I hope you will learn valuable lessons by hearing more about our successes and challenges. I'm delighted to share with you the work of Memory Care Home Solutions. We're a nonprofit organization in St. Louis. MCHS was founded in 2002 by Lisa Barron, who found her own family thrust into dementia caregiving, but recognized a total void of support in the community for families trying to manage dementia progression at home. So MCHS has a mission to extend and improve quality time at home for people living with dementia and their families. Our program staff is comprised of social workers and occupational therapists, and we serve a bi-state region of Illinois and Missouri. In our last program year, 445 new families enrolled in our individualized programming, and thousands more were served through professional and community education events. So since 2002, we have been delivering evidence-informed in-home services to guide families. Prior to COVID, all services were delivered in families' homes or in our dementia training venue, which is a home-like setting complete with bedroom, bathroom, kitchen, and living room. Since COVID, we have been delivering a hybrid of virtual and in-person service for the safety of this obviously very vulnerable population. But the goals of our service have always been to provide person-centered care, to transform the home into a safe environment where people with dementia can function successfully, to improve overall well-being and health, and to prevent or delay the need for nursing home care. So as part of our ACL Collaborative Grant, we set out to build a dementia-capable network and align our work more closely with an evidence-based model. And because it was also the goal to improve the sustainability of our work, which had historically been funded entirely through grants and philanthropy, we narrowed our search for an evidence-based program to relevant options with health insurance billing potential. So our work was already informed by 3 evidence-based programs, which are Skills to Care, the Tailored Activity Program, and COPE, which stands for Care of Persons with Dementia and Their Environments. Really interesting to note that all 3 of these interventions had already been trialed in studies with health insurance payment models, ranging from Medicaid reimbursement to Medicare Part A home health benefits. So we felt fairly confident that any one of these might work as an outpatient service. We selected COPE because it demonstrated positive outcomes in clinical trials and combines the most effective components of Skills to Care and the Tailored Activity Program into a comprehensive home-based intervention. As originally designed, COPE is a non-pharmacologic intervention delivered by occupational therapists and advanced practice nurses with a focus on assessing the health and functional ability of the person living with dementia. And then COPE equips those people's care partners with education, skills, and a problem-solving framework to address the functional decline and behavioral symptoms associated with dementia. So then we worked very closely with COPE developers, Drs. Laura Gitlin and Kathy Pearsall, to make the necessary modifications to translate COPE into real-world practice at our organization. For example, we don't have advanced practice nurses on staff, so we shifted this role back to physicians who we coordinate care with. But we loved that COPE focused on the dyad of person living with dementia and care partner. But we asked ourselves, who is the patient in this intervention? We would need to know under whose health insurance benefits to bill the service to. And at the same time we were contemplating this question, we also noticed that care partners were consistently requesting more help to manage their own self-care and navigate community resources. So we defined the roles based on the disciplines of staff we had. We defined the role of social workers to focus on these self-care and community resource issues, while OTs focus on the functional and behavioral challenges associated with dementia, all while staying true to the core principles of COPE and engaging the dyad at every step. As a little Medicare refresher, Medicare Part A covers services like hospital and skilled nursing facility care, hospice, and home health. Medicare Part B covers medically necessary outpatient care like doctor's visits. And we're not a facility-based provider of care, so we knew we needed our services to fit into the Medicare Part B bucket. So then we explored whether the OT's role in COPE would be covered. The Medicare Benefit Policy Manual, Chapter 15, to be precise, is the go-to resource for this topic. Medicare does indeed cover outpatient OT services when they are medically necessary to improve functions impaired by illness, to improve or restore the person's ability to perform tasks required for daily function. And the manual further specifies that rehab therapy may be needed even when, real important for our population, even when the patient has a chronic, progressive, and degenerative illness, if the treatment will maximize his or her functional abilities. So we felt COPE met these requirements well. Additionally, to be covered, services must require the skilled intervention and clinical judgment of qualified OTs and be provided to patients who are under the care of a physician, nurse practitioner, or physician's assistant. and the OT plan of care must be certified by the physician, and all documentation must support the medical necessity of the care. So prior to our ACL grant, we were providing free consultative OT services. The switch to outpatient billing meant that we would need to coordinate more closely with physicians and seek approval for OT in advance and obtain signatures on plans of care. So we decided it made the most sense to bill OT services under the benefits of the person living with dementia, because the goal is to maximize their function for daily living. Next, we considered the case for our social work services. Because we are not associated with a physician's office, we could not use some of the care management codes that you will notice in the billing guide. Donna showed you that column which says who can bill for the services. And there are many services which need to be billed by or incident to physician services. So we explored outpatient mental health coverage because our social workers happen to be licensed clinical social workers. So again, the Medicare Benefit Policy Manual, Chapter 15, defines this coverage. The coverage is considered medically necessary when it's provided to diagnose and treat mental health conditions like depression or anxiety, and when provided by qualified health professionals, including clinical psychologists or clinical social workers. Not every care partner experiences mental health issues related to caregiving, but many do. We only bill social work services for those care partners who need psychological assessment and treatment, and for whom our documentation supports this need. Next, we had to prepare our organization and providers to bill Medicare and other health insurance plans. We did not use a credentialing agency, and instead we navigated this process in-house. The billing guide, which I hope you will download, outlines insurance credentialing and provides excellent online resources. So first, we obtained national provider identifier numbers for our clinicians and for the organization as a whole. And then we enrolled the providers and the organization in Medicare using the online enrollment system called PECOS, which stands for Provider Enrollment Chain and Ownership System. So many acronyms. And lucky for us, because we serve a bi-state area, we had to enroll in Medicare twice. Once with the MAC covering our Missouri region, which is Wisconsin Physician Services, and again with the MAC servicing Illinois, National Government Services. To test the waters of billing, we did this process first with our occupational therapist, and then we enrolled our social workers a little bit later. Once Medicare enrollment was approved, I should go back and mention something here. Because we also wanted to enroll with Medicare Advantage plans and other third-party payers, our next step was to credential our providers with CAQH, hopefully the last acronym for the presentation, which stands for Council for Affordable Quality Healthcare. CAQH reduces the burden of credentialing by maintaining profiles on all your providers so that each new payer can quickly verify and enroll your providers. So this means that we didn't have to repeat the full credentialing process once we secured new contracts with other payers like Anthem or United Healthcare. Instead, these plans verify our credentials directly through CAQH. And again, the billing guide is an excellent reference on this topic. Next up, we customized session protocols and modified the assessments for our COPE translation by working directly with the developers of the intervention. We had hoped to use an off-the-shelf electronic medical record system for documentation and billing, but given our size as a small practice with relatively low claims volume, and the fact that we work exclusively with a population of people with dementia and caregivers, we could not find a product that fit our needs, despite software demos with nearly a dozen companies. We could find really good outpatient occupational therapy software and good mental health counseling software, but we had a hard time finding products that could do both of these things well. So we started by developing our own electronic forms using Adobe, and we used this documentation while we became more proficient with delivering and documenting about COPE. So after about 18 months of figuring it out and using our own system, then we felt confident enough that we could try again to customize an off-the-shelf product. So at that point, we identified a very customizable medical software called Cario. Cario is designed for independent practices because we're not affiliated with any health system. So Cario is for independent practices, and it integrates electronic health record, billing, and patient engagement functions. We did have to devote a great deal of time and effort into customizing Cario for our needs. And then we determined how to get our claims to Medicare and other health plans so that we could receive payment. This seemed too daunting of a task to handle on our own, so we engaged a billing vendor. We found our vendor by networking with other small physician and therapy practices in our area and getting recommendations from partners. So typically billing vendors handle the claim submission and patient invoicing, and then they're paid a percentage of revenue collected on those claims. We also had to establish a fee schedule and develop a financial assistance policy. As a nonprofit, we wanted to be sure that people who could not afford insurance copays or were uninsured, that they could still access our services. So a financial assistance policy ensures a fair and transparent way to provide charitable care to people in need. We also developed internal systems for tracking and reconciling this new revenue stream, which is called revenue cycle management. We needed the help of our accounting firm to get that process in place. And then similar to our documentation process where we later transitioned, to an EMR, once we had a better understanding of billing, we felt confident to manage it on our own, given the new functionality in the Cario software. So we did eventually move billing in-house. To capture healthcare reimbursement for COPE, we identified existing billing codes mentioned by Donna. They're called Current Procedural Terminology, or CPT codes, that align with the services that we provide at each COPE session. So in our translation, we bill OT codes under the benefits of the person living with dementia, and we bill psychotherapy evaluation code and counseling codes under the benefits of care partners. Our most commonly used codes are outlined here. The codes highlighted in yellow are OT evaluation codes. The codes highlighted in blue are OT treatment codes that we use the most. For OT billing, we typically use medical claims require diagnosis codes, which are called ICD-10 codes, as well as these procedure codes. So for OT, we generally use the patient's type of dementia as one of the diagnosis codes, along with a functional diagnosis code like need for assistance with personal care. So we document the condition and the functional impairment. For social work billing, the most common diagnoses that we use are anxiety, depression, and adjustment disorder as some examples. So after identifying CPT codes, it's important to search for any local coverage determinations that may affect the use or documentation required when using the codes. And just because one payer will reimburse for a code does not mean another payer will do the same. And there can even be variability between Medicare administrative contractors. So in our case, we are sure to check for local coverage determinations from both of the MACs that we work with. And just as an example, there was an OT cognitive intervention code called G0515 that was just discontinued this year and was replaced with 2 new CPT codes. So this process is constantly evolving. Our practice, it's the role of our practice manager to stay apprised of these annual updates, and he lets us know when we need to make adjustments in the codes that we use. And now for some examples of how we use these billing codes in COPE delivery. So our OT evaluation is a 2-session process. On the first evaluation visit, we're assessing the functional abilities of the person living with dementia for self-care and daily activities, the safety of the home environment, and the ability of the care partner to assist with the daily routine. And we select one of the 3 evaluation codes listed here based on the complexity of the assessment and the complexity of the person's health conditions. At our second assessment session, we typically use code 96125 for cognitive performance testing, because we generally are, at the second visit, are completing the Allen diagnostic module during this visit. So, and when you bill for cognitive performance testing, it's a requirement that a written report with interpretation of test results is generated. And we love that, because we then use this report, we share it with families at the next visit as an educational tool to explain in detail the level of cognitive ability and the level of supervision required for safety. So it provides great information for families. The evaluation codes are untimed codes, but OT treatment codes are generally billed in 15-minute time-based units. The code we use most frequently is 97535 for self-care and home management training. We use this code when we are working to modify the environment or simplify tasks so the person with dementia can complete their routine successfully. We also use this code when we are working with patients and their care partners on brainstorming and education to address difficult behavioral symptoms that are interfering with self-care. So for example, we often work with caregivers on strategies to overcome the patient's resistance to bathing. This is a common challenging area that our families report to us. So we might use this code while we're teaching strategies such as cueing and communication techniques, like single-step cues to lead the person into the bathroom rather than asking them, do you want to take a shower? With the goal that the person with dementia becomes more independent with bathing and the caregiver becomes more skilled and less frustrated in helping them accomplish the task. Another frequently used code is 97530 for therapeutic activities. For many people living with dementia, the behavioral and psychological symptoms of dementia are more debilitating than the memory impairments. So it's part of COPE to identify the preserved abilities of the person living with dementia and then prescribe activities that can be used as caregiving tools to decrease the manifestation of difficult behaviors. So for example, for somebody who is experiencing sundowning symptoms such as anxiety or constantly saying, I want to go home, asking for home, we might train the caregivers in communication, cueing, and redirection techniques to engage the person in meaningful tasks. And then that reduces the person's fear, provides a sense of purpose, and stops the urge to leave or wander. For social work services, we use code 90791 for an integrated biopsychosocial assessment when we are evaluating the mental health needs of care partners. We use standardized tools to assess care partner well-being, health status, coping strategies, and stress management. And I've listed some examples. So we use the Perceived Change Scale, which is a measure of overall care partner well-being. The revised Memory and Behavior Problem Checklist measures the level of care partner distress and upset that is triggered by their person with dementia's challenging behavioral symptoms. So it kind of illustrates for you how all of our services, even those billed under separate beneficiaries, are still focused on the dyad of person living with dementia and care partner as one unit. Follow-up social work visits are billed using timed psychotherapy codes. These sessions are used to guide care partners in identifying triggers for their stress and anxiety and to modify their thoughts around caregiving strategies and stress management. Caregivers also learn specific techniques to cope with grief, to prioritize their own self-care, and plan for the future. All of our social workers are trained in cognitive behavioral therapy, motivational interviewing, and solution-focused brief therapy, and they incorporate all of these approaches into their counseling. As you can see, COPE implementation and billing requires a tremendous amount of work that fills a very important void in home and community-based dementia treatment. COPE can be delivered through health insurance, but it isn't easy. We are one of those organizations, like Donna mentioned, that had no billing mechanisms in place prior to this project. So this would be a much easier endeavor for organizations who are already enrolled in Medicare and managed care contracts. We have learned that our current dyadic billing system is burdensome for clients and our staff and does not truly cover the cost of providing an outpatient service in people's homes. Additionally, we cannot bill for outpatient Medicare Part B occupational therapy while people are receiving Part A services like home health. So we've encountered that some of our patients are in home health episodes and don't even realize it. And therefore, some of our claims are denied because of this. It can also be very complicated to schedule all of the COPE sessions within a 90-day plan of care, given the challenges of coordinating schedules with at least 3 people, the care partner, the person with dementia, and the clinician. But despite these challenges, all still very worth it. And on a positive note, the only denials that we have received from payers are related to administrative or timing errors. And the good thing is those claims can be corrected and resubmitted. We have not actually received any denials based on the content of the care we provided. So where are we today? At Memory Care Home Solutions, we're in the final year of our ACL project, and we are very committed to continuing this work. COVID has changed the landscape and opened doors for telehealth delivery. We began this project with 0 telehealth service. Telehealth social work was approved prior to COVID, but it was the CARES Act that made OT telehealth reimbursable for the first time. So we quickly modified our COPE protocols for telehealth delivery so that we could continue serving this population. Early in the public health emergency, we were providing entirely telehealth services, but we've moved into a hybrid model and look forward to spending more time in our patients' homes as soon as it's safe. And just a note on technology and telehealth, we began with Zoom for healthcare as our telehealth platform, but we recently transitioned to Doxy.me because it's easier for our clients to use. So we do many things at MCHS in addition to our individualized family treatment. So we knew that billing for COPE was never going to sustain all of our work, but it did introduce additional costs because we had to hire some admin support staff for scheduling, coordinating with physicians, and billing. But we now have a line of revenue that helps to support about 10% of our program budget. And most of all, we believe that all people should have access to home and community-based treatment for dementia, just like they have access to care for their other health conditions. We look forward to applying all the lessons we've learned to make evidence-based dementia treatment even more efficient moving forward. And I'd like to acknowledge all of the experts, staff, and most of all our families who contribute to the success of this program. Special thanks to our incredible program officer, Erin Long, and the ACL for making this work possible. I've included a lot of references if you'd like to learn more about the body of research that has built the foundation for these interventions. My contact information is provided here, and I look forward to your questions. Mary, I'll send it back.
Thank you so much, Jill and Donna, for your excellent presentations. What a great amount of information you've been able to provide to our participants today. We do have some questions coming into the question and answer pod, and I just want to remind people you can enter those questions right now as you're thinking of them at the end of this presentation. And I'll just start with a question we received about how long, what would the timeline look like for developing the billing system for your organization from start to finish?
Well, with nothing in place prior, it took us about 9 months to actually start submitting our first claims.
Great.
But I think if it's an established practice, it could happen much more quickly.
Sure, that makes sense. Okay, so can you tell us a little bit about a little bit more about the process of moving services from in-person to remote during COVID-19 and how that has changed the way you've done things. Did it change any way that you've had to bill? Can you talk a little bit about how that's impacted your practice?
Sure. Well, it changed everything about how we practice and how we bill. So, and at the beginning of the public health emergency, OT telehealth billing, we weren't sure if it would be approved, and it was approved kind of later and then made retroactively official. So we did go for a period of time where we kind of went back to our free consultative model because we weren't sure we'd be able to bill for any services our OTs provided until the CARES Act was passed. So we just to stay in touch with our families and to prevent their sense of social isolation, we started out by just biweekly phone calls to check on everyone. And while we were doing that, we reached back out to the developers of the evidence-based program to tweak one more time our session protocols for how much of this can we do by phone or video, because we feel very strongly that we wanted to stay true to the evidence-based model. So from working with our developers and making modifications, we saw there's a lot that we can do over telehealth. So some of our assessments change. There are some parts of we use Allen cognitive level assessments, which are very hands-on and functional and require hands-on materials. There's leather lacing and craft activities that require problem solving that we couldn't use. So we had to simplify some of our assessment process, and we learned in real time along with our clients, because we weren't sure if we would be able to engage people living with dementia in video visits or not. So it was very much a learning process for our families and for our staff. But what we found, kind of much to our surprise and really appreciation, is that despite serving an older adult population, many of our care partners are spouses of the person living with dementia. They were so eager to embrace new technology, and all but our very most impaired people living with dementia can engage in video interaction. So it's been overwhelmingly positive, very well received by our families, and we've gotten really creative with activities we can do together over video. We did have to put some additional administrative supports in place, so we kind of moved a data entry staff person to the job of doing Zoom and Doxy test calls with our clients prior to their visits, because we found that if we don't do test calls and help people become comfortable with the technology before their meeting with the clinician, they would end up spending quite a lot of their appointment time with their clinical staff troubleshooting technology. So we found it really paid off and maximized patient and clinician time to devote a staff person to teaching the technology and doing test calls. So that was a new process for us. But we are successfully billing now for social work and OT, and we expect that this is here to stay because families appreciate it, and we're able to engage caregivers who aren't in town but want to be a part of the visit. So we actually have more family members than ever showing up to our appointments.
Great. Thank you so much, Jill. A few people are asking, you mentioned that you had to choose which insurance you were going to bill for, the care partner or the person living with dementia. And in cases, people are asking about billing under the care partner. What do you do in cases? Have you had cases where care partners are not served under Medicare due to their age, and how do you handle that situation? Are you billing private insurance as well? Can you explain a little bit more about how that works between Medicare versus a different kind of insurance arrangement?
Sure. So yes, we did, as I mentioned in the presentation, the whole CAQH process, that was step one in pursuing contracts with other managed care commercial insurance providers. So we did start with Medicare Enrollment and kind of got those wheels turning, and then because we wanted to be able to serve care partners and people who don't have Medicare, or perhaps if they are Medicare age, they've chosen a Medicare Advantage plan. So we are in network and secured contracts with our most, we figured out who are the biggest providers in our area, and we do have contracts with commercial insurance providers. So I would say, so really the process is very much the same of submitting a claim, whether you're submitting the claim to Medicare or a different payer. But we really don't, it's not every care partner who wants or needs the more intensive psychotherapy approach. So I would say it's certainly not appropriate for every family that we serve, but when we identify a care partner who's really struggling with their own coping and processing, and then we offer the additional therapy, they're often eager to take advantage. So we haven't, like I said, not everybody needs or wants it. So everything that we do at Memory Care Home Solutions starts out with an initial assessment visit where we learn a lot about the family and the person living with dementia, and there's no charge, and we don't bill for that session. So we have the great opportunity to learn a lot about our families before we offer them our additional services for which we bill their health insurance.
Great, thank you. Can you talk a little bit about how long the training takes to train OTs and social workers in COPE, and also you talked a little bit about social work methods that your social workers are trained in. People were asking for a little bit of a refresher on what you mentioned there.
Sure. So our social worker, so let me start with how long does it take to train for COPE. So in the 9-month lead up that I mentioned about how long did it take us to get billing and coding processes in place, during that lead up time, we were all training in COPE, our OTs and our social workers. So and you can do this at your own pace. You can do a crash course and do it really intensively and quickly, but we did online modules, we did coaching calls with the course developers, and then because we knew we weren't going to be billing right away, we started picking pieces of COPE to practice and develop competency with. So, and I know our organization is unique in that we already only serve this population, and our clinicians weren't newly hired. I mean, they were already on staff with Memory Care Home Solutions and already very familiar with the unique needs and complexities of a dyadic approach to care. So, it took us a good 3 to 6 months to feel really confident in delivering COPE, but we also had the luxury of that planning time. So, I mean, I would say you need some mentorship, you need to observe other people doing it, you need to present cases and develop competence in the intervention. And the course developers told us that you will not feel confident in delivering COPE until you have completed 5 to 6 dyads. And our families average anywhere from 4 to 12 visits. So it can take you a long time to go from start to finish with up to 12 sessions with 5 complete families. So that was really excellent guidance for us, and it allowed us to be more patient with ourselves as we were learning this. As part of our ACL grant, we also partnered with a rural health system, and we did more of a train-the-trainer model with COPE. So we trained a rural health system's existing occupational therapy staff to deliver COPE visits. And I can tell you that it was a much harder process for them to feel confident in COPE because their therapists were practicing with a very general, broad caseload. So the same therapist might see a pediatric patient in the clinic and then go visit an orthopedic adult patient in the hospital and then go out into the community and see a person living with dementia and do a COPE session. So it was a much harder transition for those staff, but they were still really found the intervention very valuable. They needed more time to prepare for each session, and they needed more support in terms of case conferencing and support with our staff, because we have designated time for that. They didn't, so we carved it out and supported the rural therapists. So that's a long and complicated answer for, it's all very dependent on your practice type and the population that you're serving. But our social workers did additional training in cognitive behavioral therapy, CBT, and also motivational interviewing and brief solution-focused therapy. And all of those really lend themselves to the COPE model, which is, COPE's all about identifying the priorities of each family. Like, we don't impose goals on families. It's truly driven by whatever is troubling that dyad. So it's very culturally relevant for each family, which lends itself very well to motivational interviewing. And it's very much about brainstorming and problem solving. So it was very appropriate for brief solution-focused therapy. And in fact, our social workers found that additional training on motivational interviewing was so helpful that they encouraged all of our therapists, so even our occupational therapists have done some training in motivational interviewing, because it allows us to really not be so focused on an outcome that we might hope for a family to achieve, and really focus on the outcomes that they can realize for themselves. So the additional training has been great for our staff.
Great. Thank you so much, Jill. You mentioned about the percent that you're receiving back in reimbursements, and someone asked a little bit different question is, what percent of your clients are you billing for?
We are billing for about a third. I would say, a third to a half of our clients who participate in individualized family programming. And we do many other things in our program department, like teach and do educational workshops. So we're, and I mentioned that it's providing about 10% of our program budget, our billing is. And I would say the activities we do around billing are certainly more than 10% of our activities. So, but again, we're fortunate to be really a philanthropic model. So we have the luxury of not needing to cover every single expense through the billing, but we do hope to move it. It's a goal of ours to move our funding mix to more of a 30% billing revenue stream, 30% grant funding, and 30% philanthropy. It's kind of more a mix that we're striving for.
Great, thank you so much. I hope that this last question was answered when you responded. Let's see. So this is, in the few minutes we have left, this is a great question. Just given the challenges that you had getting the billing up and running, do you think that this has delivered a return on your investment for the agency? Whether financially or just in terms of what you see it doing in the future, you know, do you see the return on your investment on the horizon?
Absolutely, and really in measurable and immeasurable ways, because as I mentioned at the conclusion, you know, if organizations don't push this envelope a little bit and look for reimbursable ways for people to access dementia care, then it will never be a living, breathing option for people in the community. So we feel like the opportunity to blaze a trail, to inspire others, and to push in whatever ways that we can for more innovative payment mechanisms that much more comprehensively, instead of piecemeal, fund the sort of work that we know people living with dementia deserve access to, and that we know in the long run saves families and society a tremendous expense by keeping people at home where they want to be, keeping them with their families for quality of life, and really saving on facility-based healthcare costs. So you know, we hope that this is just the beginning of much more reimbursable dementia treatment at home and in the community. But you know, there was such a learning curve that we think the efficiency of our clinic-based services will only continue to grow. So for our own organizational return on investment, we absolutely see this as an extremely worthwhile endeavor, and know that it will only become better with time.
Great, thank you so much. And that's the last question we're going to have time to answer today, but I do want to thank you again, Jill and Donna, for your excellent presentations, and I want to thank all our participants for attending today. We're excited to announce that we have a few more webinars on the horizon. We have the next one on the American Society on Aging webinar platform on November 19th, focused on maintaining services and supports for people living with dementia and their caregivers during COVID-19. The registration information is already posted on ASA's website. Prior to that time, we have another COVID-19 and dementia-focused webinar on November 2nd. The information for that webinar can be received through emailing me, and I can send it to you if you haven't received it already. And I will send out my email address in the question and answer pod right now so you all can have it. So I want to thank you all again, and we look forward to seeing you at future webinars. Thanks so much. Betsy, do you have any final comments?
Yes, just thank you so much, first of all, for this great presentation. I just want to remind folks that if you'd like to claim CEUs for this web seminar, you'll receive a follow-up email by the end of the business day that will contain a link to the CEU application. That follow-up email will also contain a link where you can download today's slides. You'll have 60 days to claim CEUs for this event, and it will take 30 days from the date of your submission in order for us to process and issue your CE credit. Thank you, everyone, for joining us today. Have a great rest of your day.